So I began thinking that global health in the 21st century for us represented the aging of the population worldwide and the changing patterns of disease that this brought. It required new solutions and new technologies. We had to learn how to implement what we know. We know a lot about hypertension. We don't know how to get hypertension treatment programs into the field and how to get people to be adherent to treatment, whether it's for hypertension, for statins, for cancer therapy, for antimicrobial agents. We need to think about the revolutions not only of biomedical science, but engineering, but also M-Health, information technology, long-distance learning, all of these which would allow us to work more globally tomorrow, more than we had today. And multidisciplinary programs. And we have a framework grant at Fogarty, one of which came to Michigan, where it's not in the School of Public Health or medical school, it's at the level of the university, and it requires that the university bring together not only medical schools and nursing schools and schools of business schools because of supply chains, law schools because the Framework Convention for Tobacco was a legal document, but it was a major importance for human health. Economics, we saw with Dean Jameson, behavioral studies for implementation. Global health must be much broader. Well, I came to NIH and I started going around to the different institutes and center heads. I started with Tony Fauci, who's really the guru of infectious diseases, and he showed me here that global health for him was emerging infections, the idea that any infection anywhere in the world could be on our shores in one plane ride. So global health was clearly infectious diseases. Then I went to the head of the Cancer Institute. He said, well, you know, 85% of the cancers in the world today and the cancer deaths are in low and middle income countries. So really, cancers are a global health issue, and many of those cancers have an infectious etiology, papillomavirus, EB virus, and the like. So cancer is really a global health issue. And if you see that red area in the map in the middle of Africa, amazing discoveries happen there, and I'll tell you about them. I also spent some time at Oxford with Sir Richard Dahl, really well known for the doctor's smoking study. And when I was there in the 70s, he had just finished 20 years of the doctor's studies, which documented that cancer and heart disease were major killers of people who were smokers, physicians who were smokers. And we said, Sir Richard, why don't you say something political? Why don't you take tobacco off the stands? This is the biggest impact that you could have. He said, no, Roger, I'm an epidemiologist. I'm not a politician. I don't do that. That's for the politicians. And consequently, it took 20 years for smoking to decline. In England, you can see here the lung cancer mortality coming down nicely over the past 40 years. Across the English Channel, 26 miles away in France, you can see just the opposite thing happen. So clearly, while we had the knowledge, we didn't have the knowledge to implement. And this is clearly a problem globally. And when you think about China today, they say 1 in 3 smokers in China will die of their smoking. And something like 60 to 70% of physicians smoke, just like in the United States in the 50s. Isn't there something we should be able to learn and to teach? And is smoking problem gone away in the US? Is the tobacco problem over? My son, who's in college, thinks that smoking a hookah is really in. And yet, 20% of Americans smoke. Hookah smoking is still hazardous. Cigarettes are a major US export. And there are new ways to use tobacco that specifically target our young. We haven't begun to fully address the tobacco problem. Well, going back to that red zone in the map of cancers in Africa, here's a physician who went out to Africa as a young man, Dennis Burkitt. He ended up at Mulago Hospital in Kampala and found patients, these patients like this with big lymphomas of the jaw. And he found this was African lymphoma. It was later called Burkitt's lymphoma. Very important, because when we think about cancer, is cancer a problem in the United States? Sure it is. And what's the etiology? Well, this was the first demonstration that viruses cause cancer. EB virus was linked to cancer, not because of studies in the US or Europe, but because an observer, a skilled observer working in an African setting with his colleagues, identified a new form of cancer, linked that to a virus, and opened up the idea that viruses can cause cancer. And now there are a number of infectious agents that cause cancer that are all addressable by infectious means if we put our resources to them. He then went to Sloan Kettering in the 60s when anti-chemotherapeutic agents were being developed. He took home some methotrexate in his pocket. He gave it to those patients, and in 2 weeks, their cancer melted. It was the first demonstration of chemotherapy that showed its efficacy and really charged the community to think that this was an approach to go. So this is clearly learning from African settings, African problems, adapted to our own work in the United States, where we've all learned about cancer, its etiology, its prevention, its treatment. Well, I then went to Francis Collins, who was in charge of the Genome Institute, and I said, Francis, what is global health to you? He said, Roger, we have a melting pot in the United States of people who have come from all over. This is the signature of the United States. People have brought their genes with them. And we have a hard time figuring out everything from the genes of Americans because they're all mixed, but we have them all, and the genetic diseases of the world are on our shores. And as I was graduating from college, you remember this guy, Woody Guthrie, singing "This Land Is Your Land"? One of my classmates, Nancy Wexler, found that as she graduated, her mother came down with Huntington's chorea, just a devastating neurologic disease. We have a couple 100,000 people in this country who have the gene of Huntington's, about 20,000 new cases a year, and she had a 50-50 risk of having this. Where did she go to find the genes of Huntington's? To a small area in Maracaibo, Venezuela, where a single woman who migrated from Europe in 1824 brought the genes, went through 6 generations of grandchildren and great-grandchildren to the point where there's such a concentration of patients with Huntington's that the genes of Huntington's were found in this community. And the gene was actually discovered by Francis Collins, but it was because of the epidemiology and the concern of this community for people who were developing this disease. Well, if you look in the audience, and if you look particularly at older people in the audience, 1/3 of us will come down with Alzheimer's before we die. So it's one of the most costly diseases we have. Where will we find the cure and the prevention and the studies of Alzheimer's that will be most productive? Well, we have so many cases in the US. They're slowly progressive. There's a great diversity. But in this community in Colombia, just like the community in Venezuela with Huntington's, there is a community that's been studied, well studied, going back to a single woman who came to Colombia in about 1745. Here's her family tree. It's a community that has a high prevalence of Alzheimer's disease. It presents early in life at 35 or so, a high penetrance by age 40. If we're going to understand biomarkers for Alzheimer's disease and monitor treatments as it goes forward, this is the ideal community to work with. It's a devastating public health problem in Colombia. It's a major problem in the United States as well. And now patients, the genes have been identified as a Pisher mutation. Patients from this community are being brought to the United States to be able to find early markers of disease and disease progression and to begin to think about new treatments of disease. Not in the American community where the same studies would take ages with long progression and mixed genotypes, but here in a group where the genes are very well known and the treatments could be worked out. Another advance where global health research and a public health problem locally could help us globally. And this goes on, environmental disasters, and Tom has worked on these here at Michigan. Clearly, they're global problems. We could all suffer a nuclear meltdown. The fact that it's in Japan doesn't mean it's any less importance to us. If not, it's really more important because we can understand how we might react if this were to happen on our own shores. So I got to Fogarty, and here was my mission. and the Fogarty mission to address global health challenges through innovative and collaborative programs of research and training, and to support and advance the NIH agenda and mission through global partnerships, science for global health. And so this is what I've been doing really for the last 6 years. Fogarty is one of the 27 institutes and centers at NIH. We work with almost all of them. And when I got there, the issue was, what is in our portfolio? What can we do? And I learned at NIH, and many of you have looked at the NIH catalog, we're full of acronyms. And I was greeted with all of these letters, some of which you're familiar with here at Michigan. The framework grant that you have, the ITRIO grant that in environmental and occupational health, the AIDS International Training and Research Program. But all of these had some common themes. One was collaborative research and really good, strong partnerships between U.S. and foreign institutions. Another was research training of both foreign investigators and U.S. fellows, and the development of institutional capacity, because we see the global community as a community which really on the frontiers of research and where we need to help. Well, our first program, signature program, was this AIDS International Training and Research Program. We took, in 1988, AIDS was a U.S. problem. We didn't think about the tremendous mortality that would be occurring in Africa over the next several decades. So we took young physicians in infectious diseases, we brought them to the U.S. and trained them in AIDS because we had the population of patients and we've been doing the studies and the first drugs were being developed. They've gone home and they are now absolute leaders 20 years later in the research endeavor. And almost every major advance in drugs, in microbicides and circumcision and vertical transmission studies has been done through the work of many of these people. They are really the leaders. They are collaborators, shoulder to shoulder, working on diseases where we share a common interest and we value the common results. So that was really a model to me of what we can do and how we should be doing things. And the ITRIO is another program just like that for environmental and occupational health. Well, who are the leaders of global health in the U.S.? I did a little landscape analysis, and you may know or recognize many of these people. And I scratched my head and I said, isn't this an interesting picture? I said, first, they're all old white men. Okay? The second is that except for Alan Rosenfeld, they're all in infectious diseases. So this is in the 20th century, but they had one thing in common, and what they had was that early childhood exposure experience. They all went overseas early in their careers. They got so glommed onto a project of interest that they didn't change their orientation. And whether they came back to work in the U.S. in issues of equity or in global health, they remained as leaders in their field, doing something that they probably never thought they would do when they were in medical school or in early training. So we said, how can we change this picture? We do have a very active program of fellows and scholars. We've had many people from Michigan involved, both medical students and postdoctoral programs. And this has been one of our signature programs and a program that we have been growing since I've been there. In fact, we just recompeted this. We've gone from one center handled by Fogarty to one center at Vanderbilt, now to 5 consortiums. Michigan is part of one of the consortiums, and we have new fellows this year. And we've had buy-in from 17 of the institutes and centers of NIH, who all see this as a way for them to develop research scholars and partnerships for tomorrow. We can find infectious disease people who have worked in low and middle income countries all over, but we have a hard time finding a cardiologist who's worked and thought about developing country issues, a cancer specialist and beyond. So this is our program, Fellows and Scholars. We're going to have about 80 fellows and scholars this year, and I hope that that will grow in the years to come. And they'll spend a year in research, developing research proposals. For the fellows and postdocs in any specialty, they will use this experience to build a partnership, to start their research activities, and to get further funding to continue what I would say would be a long-term relationship, a love affair, if you will, in research. We also have moved on for people who are not in the consortium to have the Fulbright Fogarty Fellowships. I had a Fulbright early in my career. About 30 years ago, they said, you know, biomedicine is something different from what we do at Fulbright. And they really were dismissive of the idea, or put less emphasis on the idea of public health. We've been back speaking with them for the last several years. We now have a Fulbright Fogarty program for both medical students and postdocs to spend a year in a lower middle income country working on a health priority. And it works both ways. Foreign scientists can come to the US. And the specialties that we'll accept will be almost anything on the NIH scoreboard, be it engineering, IT, law related to global health and the like. And our scholars have done amazing things. You're going to be hearing from your own scholars this afternoon, so I'm not going to dwell on some of the interventions. Another area that we've seen as a trans-NIH and a very important area is mobile health and using ICT, information communication technology, to advance our global health agenda. So we've had a mobile health symposium. The next one's in December in Washington. We started out 4 years ago thinking we would have about 150 people interested in mobile phones and their use in medicine. Last year we had 3,500 people. This year, 5,000. Incredible razzle-dazzle technology. Some of the ideas are absolutely wonderful. Evaluation, implementation is really quite meager. There's a paucity of research in this area. That's something where NIH and researchers like you in academia can really provide us the feedback we need. For instance, Francis Collins, Dr. Collins was in India, and he demonstrated on TV. He had an iPhone with an EKG monitor that fed back to his cardiologist in Los Angeles who was doing a research study. It seems like a no-brainer to be able to monitor your heart if you have an arrhythmia. Doesn't that sound wonderful? Well, there have been 2 people who have had cardiac surgery because their monitor picked up an arrhythmia that didn't need to be treated. But for whatever reasons, it was a complication. So we clearly have something to learn in ideas and innovations that have to be proven, demonstrated, limited, and perhaps regulated. And the number of these devices that have come out from mobile technology are fabulous. Cell phones that are linked to microscopes so you can look for sickle cell in Africa. You can look for infections of different sorts that can feed to computers and be read by others for confirmation. Real-time adherence programs for monitoring therapy, be it for TB, for cancer drugs, for hypertensive meds. The idea that you can identify using compliance programs people who are good in compliance and people who are bad in compliance. So you can work through and put your resources in the proper place. Physician training and physician training for the 21st century. Here's what the physician distribution looks like globally, and you can see in sub-Saharan Africa a real paucity of physicians. We have a medical education partnership initiative which is new, and we're providing grants with the partnership of PEPFAR and with HRSA to 13 programs in 12 countries, and many of the people in the audience are from institutions in Africa that receive grants from this. The idea here is that with PEPFAR, this was an emergency program to start AIDS treatment and prevention. Lots of NGOs were involved, and it was really an emergency basis. Now that that was demonstrated successful, now that the price of antiretrovirals has come down, now that new strategies for prevention are available, implementation for this and other programs needs to be done locally by local researchers, by local physicians, nurses, paramedics, and the full distribution of health professionals. So this program is to build up that capacity in Africa, as well as the research capacity. And I was just at the 2nd annual meeting of the MEPI Consortium. You can see a couple people here with a Michigan tag on their chest next to Minister Tedros. Joe Kolar's wherever you are, and Sanayat were there specifically working with this group to build up training and here in OBGYN. And Sanayat's done an amazing job to build up the ability to train obstetricians and gynecologists so that problems like fistula and fistula repair, safe delivery, maternal mortality can be addressed. What an amazing contribution and what an interesting research agenda that's been developed right here connecting Michigan to Ethiopia. Well, another agenda that's on the horizon, clean household air pollution. And answering and addressing the question, will clean cook stoves improve health? You know, it's estimated by the WHO that there are about 2 million deaths a year from indoor air pollution. And indoor air pollution really harms women and children who are indoors at cook stoves in contaminated, polluted areas. So it seems like a no-brainer if we can put in clean cook stoves, clean up the indoor air pollution, and improve health from a variety of diseases, be it from low birth weight of infants to acute respiratory disease in children, TB, synergisms, cancer, cardiovascular disease, chronic lung disease, eye disease, and the like. It's just like clean water in Bangladesh. It seems like a no-brainer to clean up the indoor air pollution, but how we do this, is it effective? Is there a research agenda which can go hand in hand with implementation? Well, the Clean Cook Stove Alliance is trying to introduce 100 million cook stoves by 2020. And NIH is partnering specifically so we can get the research agenda and figure out how much we have to reduce indoor air pollution, what are the true benefits, what are the risks, what happens in Tibet where that warm cook stove indoors is part of the heating system, and will this kind of initiative work in those kinds of settings? So here you have Tom Robbins working on just this kind of research and thinking about environmental health and pollution right here at Michigan. And another area and opportunity for students has been this Peace Corps for doctors. We've said that in our MEPI programs, we do a lot for research, we do a lot for undergraduate training of nurses and doctors. How about the clinical training, which requires hands-on, shoulder-to-shoulder demonstration of good techniques, of values, and the Peace Corps has been working with us to get 3 teams for next year of doctors and nurses to go out to our MEPI schools, to start with 3 schools, and see if we can help stand up the level of clinical training so that we can instill in the next generation of physicians in training values, ideas, and bring them into what we would call optimal clinical training experience. Implementation science. An area that we've been wonderful at NIH to develop new vaccines, new drugs, new ideas for treatment. We haven't been so creative in how to get these ideas implemented. Is there a research agenda around behavior, around sticking points to identify that would help implementation into action, to help implement many of these interventions as we go forward? That'll be another area that we see advanced in the future. So at Fogarty, we're a little bit like the watering can for this type of capacity building, for research and for interventions, with many collaborative relations. Our strategic plan has focused now for the 21st century not only on the infectious diseases and HIV, which are clearly critical in Africa and around the world, but also the non-communicable disease agenda. We're thinking about implementation science and how to bridge that gap. We're working in a critical area. A priority for us is developing human capacity, of fostering sustainable research environments in low-income countries, and in building strategic partnerships and alliances. I think in global health today, no one can do it alone, and we've been working closely with WHO and the World Bank, now that Jim Kim is there, with universities like Michigan, with other government agencies. I mentioned the Peace Corps. We have a program with USAID called Peer Health to partner and support researchers in low-income countries in implementation studies, with the private sector, with public-private partnerships, foundations, NGOs, and of course the other institutes and centers at NIH. So I've become an astrologer. Why an astrologer, a scientist? Well, I've seen the stars align. I've seen the president with commitment to research and global health. I have an NIH director who's put this as one of his priorities. We've had now the development of the Consortium of Universities for Global Health, which is in a sense an interest group of universities that feel that global health is important and can support the agenda, the global agenda, and in so doing supporting us at Fogarty. And with unique opportunities in the world for interventions and advances. So I am an astrologer because I really do see this, the stars have been aligned, and it's through these partnerships that good things will happen. Of course, funding in global health, despite our wildest imagination in 1997, have skyrocketed and are really sustained despite all the politics that we hear in Washington. Here we have the first meeting of that consortium. It's like an interest group for global health. Notice the gender and age of this group of people. This has to change in the next generation. Of course, the NCD agenda, which is taken on global perspective with the UN General Assembly. Of course, the shape of things to come, the problems that we're all going to be facing as we go forward. Not only obesity, addictions, the environmental hazards, climate change, health equity, both abroad and at home. And here's Dr. Collins, who's put on his 5 topics, expanding research into diseases affecting the developing world. Why would Dr. Collins, a geneticist, think so warmly about global health? Well, as a young physician, he went out to Nigeria. He worked, he was at Michigan, actually. He went out to Nigeria. He worked as a physician. He found patients who came in with diabetes who weren't the normal phenotype of diabetes. And he said, there's something wrong here. There's something different. And he found, through this experience, the first genes of diabetes that were isolated. So we've learned something from his work in global health and his continued interest, even though he's not on the front lines of global health in the sense of being out there doing this all the time. He has a tremendous concern for this, and we're all the beneficiaries of this concern. What can Michigan do for global health? You're already doing a lot, and I really applaud you for what's going on already. Encouraging electives of students and faculty, building your partnerships in these caring, twinning relationships, encouraging innovation and distance learning, engaging the larger academic community, like the framework programs. So there are many opportunities available, and the time is really right for this. So I applaud you for what you're doing, and I hope that through Fogarty's programs and many others, you'll continue. I'm often asked, and I was asked by a congressman, why, going back to a state with lots of tax money, he said, why should we invest in global health? And I told him my story about oral therapy, and I told him a bunch of these stories where he never knew that what he was benefiting from, whether it was cancer chemotherapy or treatment of diarrhea in his own children, were the response to global health research. So I said, really, it's good for science. It's the next frontiers, the genes and the environmental exposures and the cancers, what we've learned. It's good for diplomacy. It's really smart power. This was called by Hillary Clinton smart power. It shows the humanity of the Americans, the correct health. We can correct and address health disparities. And what we see overseas, we can bring back and learn at home. It's good for business and competition. It's good for a war on terrorism. It's good for our own future. It's just the right thing to do. So with that, I want to thank you all for asking me to speak here. I must say I'm most impressed by what you're doing at Michigan. I'm delighted to see so many students in the audience because I just remember in listening to the president, the words of Kennedy when he launched the space program. And he said, we're going to put a man on the moon by the end of the decade, 1969, when they arrived. In 1969, when man was landed on the moon in Houston, the average age of the engineers in that control center was about 27 or 28. Those people who were controlling the moon landing were not in college or were just entering college when the challenge was issued by Kennedy. And so it's really in the youth that we're going to see the fulfillment of these global health ideas and agendas for the future. So a lot remains in your hands, and I wish you well, and I'm delighted that you've highlighted this as a priority here at Michigan. Thank you so much for letting me do this.
spoke up.